We have a lot of experience with this drug. We've treated over 100 patients at Dana-Farber, and so there's a lot that goes into managing these patients, but the biggest thing is to just not be scared to treat these patients. CRS and ICANS sound scary, but we're gonna go over and go through some cases to make sure you guys are more comfortable when you see these patients and supporting them in clinic, okay? So now that we do have kind of a better understanding of that mechanism of action and the importance of the drug now being approved in the second line for small cell lung cancer, this is where nursing and allied health become critical at managing the care for these patients. Okay, so really, we know tarlatamab is effective. Alyssa just went over that, but it really does come with these immune-related toxicities, so the CRS and the ICANS neurotoxicity. The overall incidence you can see, where are we? On the left side for CRS is about 56%. Mostly grade 1 or grade 2. It really occurs, as most of you answered correctly, sorry, I didn't mean to give that away, we have to do the post-test at the end, but early on in the treatment course. I will say half of the patients, when they present for the first cycle of CRS, the chances of them having some form of a CRS reaction is about 50%. By the time they come back a week later, maybe about a quarter of the patients might be at risk for CRS. And really, we've exclusively seen the CRS reaction in the first two infusions. When patients get beyond those first 2 infusions, unless there's a major treatment delay, we're not seeing it. So it's really mostly exclusively those first 2 infusions, and that's where we need to really be doing our education and close monitoring around that time. And then you can see the overall incidence of ICANS, it's only about 6%. So it sounds scary, but it is pretty uncommon and more rare adverse effect. And that, again, is exclusively seen within the first 6 months of being on tarlatamab. And again, it's most of the time it's grade 1 or grade 2 in severity. And we'll go over what that means in just a few slides. But the big, most important takeaway is that patient and caregiver education is going to be really important to help them recognize the signs and symptoms of CRS and ICANS early so we can help manage these patients safely and keep them on treatment. So now how do we dose it? All right, so to be able to mitigate the risk of CRS, there's a step-up dosing. So you'll see here that the first 2 doses are given in a hospital setting where, again, I said that risk of CRS is the highest. The first dose when they come in is 1 milligram, and then when they come back a week later, they'll step up to the standard dosing of 10 milligrams. So the first cycle of treatment is given weekly for 3 weeks and then every other week. So they're in the hospital for 22 to 24 hours for those first 2 infusions. They're pre-medicated with dexamethasone. They're given a few hours of IV hydration for those first 2 infusions, and then those fall off. So you'll see for future cycles, they don't require any pre-medication. Once they're discharged from the hospital for those first 2 infusions, they do need to be within an hour of an emergency room, right, where that risk of CRS is the highest. We want to get them evaluated, so they need to be, if something does come up, and so they're an hour away from the emergency room, and they do need caregiver support, or we need to be making a plan for these patients if they don't have caregiver support. But we typically recommend a caregiver to be with them and available to help monitor for these signs and symptoms for about 48 hours. And this is where our nurse navigators, our infusion nurses, whatever your institution is set up becomes important once those patients go home to be able to make a plan amongst your institutions about who's going to be checking in on that patient after they go home, doing a safety check. So then just to move along, so cycle 1, day 15, that will be in the outpatient setting if there are no grade 2 or higher events with the prior 2 infusions. And you can see on the right hand of the screen under patient monitoring in the outpatient setting for cycle 1, day 15, they're observed in clinic for 6 to 8 hours. I will say at Dana-Farber, because again, we haven't, over 100 patients, we haven't seen any issues with CRS after the first 2 cycles. We're now only monitoring the patients for an hour after and sending them home, which, who doesn't love that? Who wants to be in clinic for 6 to 8 hours? These people are thrilled. So 1 hour at Dana-Farber, but obviously follow your own institution policy for the observation period. And then I'll go on to say, for cycle 2 and beyond, we're not even observing these patients after. We're giving them tarlatamab and scooting them out the door, and they just reinforcing that education of when to call. But that goes to show that the safety of this drug is, once you get outside of those first 2 initial infusions, it is pretty safe, okay? I think the last thing I just want to say, I don't know, in our academic setting, we have a lot of referrals from community hospitals, and so they refer the patients to us to initiate treatment with tarlatamab, and then depending on their policy, if their logistics of implementing tarlatamab at their institution, they will typically take the patient back to for the continuity of care and resuming tarlatamab at their local institution around cycle 3 or beyond. But I've seen, now that we're learning more about the drug and the safety, institutions will take them sooner. So I've seen it even just after the first 3 infusions. And this is just quickly information about dose delays. The further they get out on treatment, they have kind of more time, a little gap before we have to re-step up dosing. So if they have more than a 14-day delay after the first infusion, they do need that repeat step-up dosing to mitigate the risk of toxicities. And if you're looking at the second dose, they have 21 days, but most of the time we're seeing this if there's a major delay after those subsequent doses. If there's more than a 4-week gap in between treatments, you should consider, and these patients really should be having that step-up dosing again to resume treatment. And we've done that in the outpatient setting for a handful of our patients, but it's a select few that we do that in the outpatient setting. That takes a lot of care and coordination with your clinics. Most of the time, these patients are readmitted to the hospital. It's the safest way. So what is CRS? So cytokine release syndrome, it is a systemic inflammatory response. It can be from infection, but it also could be from drugs like tarlatamab. The symptoms can be mild, but they could be severe or life-threatening. And if you look, it can, on the picture on the right side of the screen, it can affect any organ in the body. Most of the time, I'll say these are some of the signs and symptoms. We see fever, tachycardia, low blood pressure, and maybe hypoxia, but those are the more common listed on the left side. And the median time of onset of the CRS is typically 13 and a half hours after those the infusions of tarlatamab. So that's around the time, just because that's the average. It can happen before that, and it can happen sometime after that. So especially those first 2 weeks, you want to be on high alert for these patients for any delayed CRS reaction. So how do we manage it? So on the right side of the screen is the ASTCT grading and management grid that we borrowed from our heme colleagues, but this is how you're gonna know how to escalate the situation depending on how the patient is presenting or what you're seeing based on grading. So a few things I'm gonna point out here. Grade 1 is a fever, okay? And when a patient presents with a fever over 100.4, we're supporting the patient with acetaminophen. We're getting that infectious workup. If someone presents with a fever, yeah, it could be CRS, but 9 times out of 10, sometimes these patients end up having some underlying infectious process as well. So making sure you're ruling out signs of infection alongside managing for CRS protocol. Grade 2, these patients have a fever. Now they have another vital sign change. They have fever and hypotension, not requiring pressors, maybe just some IV fluid that they need, and a fever or hypoxia, maybe requiring some low flow oxygen via nasal cannula. If these patients are getting to a point where they need pressors or CPAP, BiPAP, high flow, grade 3, they're in the ICU. I will say around grade 2, we're bringing these patients into the hospital to expedite management, that infectious workup all along. For all of these grades, you're doing that infectious workup and treating appropriately. For grade 2, this is where it says consider. We are giving steroids in grade 2. For grade 2 CRS, we are giving dexamethasone. We're not hesitating. They're getting dexamethasone, 8 milligrams IV. And we are also, it says consider. They go hand in hand. If we're giving someone dex, we're probably giving them tocilizumab, and we're giving them, it's usually a complementary approach. Would you guys agree at MSK and MGH? Yeah. So grade 2, just consider you're giving. These people can deteriorate pretty quickly, so the sooner that you all can help identify CRS and the grading and get them on dexamethasone and toci, they can turn around within hours and do quite well. And our goal is to get them home, back with their family. You know, we don't want prolonged stays for these patients. They have enough that they're going through. And it doesn't affect the efficacy to give the steroids, give the tocilizumab of the drug. So if anything you walk away with, grade 2, you're giving dex, you're giving tocilizumab. And I'll go on to say for persistent grade 1, just a fever, you've done your infectious workup, you're still giving dex and possibly moving on to toci. We're not hesitating with these patients. They end up making a turnaround pretty quickly. I've had patients, unfortunately, who have hung around in the hospital for a couple of days with a fever. They've done the infectious workup, and you're like, geez, why aren't you giving them some steroids? So gave them some steroids, maybe gave them a little toci, and they were home. Their fever resolved. And then Becca will go over the neurotoxicity, but I will just want to point out that tocilizumab does not cross the blood-brain barrier, so it's exclusively used for CRS, okay? It's not really used for ICANS. In working with our neurology teams, they've actually been recommending anakinra, which is another immune modular agent that can decrease inflammation, but you'll just want to work with your institution team, but we've actually found that that's actually been more helpful for ICANS. And just to bring it home, so the steroids we're using, right, for grade 2 CRS, persistent grade 1, for tocilizumab, not using for ICANS, doesn't cross the blood-brain barrier, helpful. We're using for grade 2 or higher or persistent grade 1. Steroids for CRS, 8 milligrams we're usually using, up to 10, or methylprednisolone, and then the toci, 8 mg per kg. You can use it up to 3 times in 24 hours. So the real key takeaway, we need to recognize signs of CRS, and I know Becca will go over the neurotoxicity component, but we need to recognize these toxicities early so we can bring these patients into clinic or send them to their local ER to coordinate care, to get a workup and get them treated appropriately. And it doesn't typically exclude them from continuing on unless they have a more severe reaction to continue on treatment with tarlatamab. And like Alyssa said, most of these patients can continue. And I've had a lot of patients who've had a really nice response now, almost 2 years on therapy, doing well. I had one patient who couldn't even climb stairs. She was an ECOG of 4. Most patients probably would have put her on hospice, but after a real goals of care and detailed discussion with her and her family, we took a chance, and she just went to Disney with her family. Like, it can really make a big difference for these people.